The assessment of the hip looks at the hip joint and the soft tissue structures of the hip, thigh and pelvis. The therapist observes the asymmetry of the hip, thigh and pelvis by asking the patient to walk, checking their gait and looking for any abnormal patterns. Walking the patient up and down on the spot and on stopping puts the patient into the neutral standing position. From this position, the asymmetry of the back and hip can be looked at, but initially we are looking at the possible leg length problems. So looking at the popliteal creases, the gluteal folds, the creases just below the gluteus maximum muscle for height differences, and by placing the thumbs into the little hollows over the posterior superior iliac spines with fingers on the crest, an imaginary line between them should be level. If it is not level, we are looking at a possible leg length problem, which can only be assessed by measurement. In order to achieve a relative accurate measurement, the patient is put into a back-lying position. Each leg is measured in turn from the anterior superior iliac spine to the medial malleolus of the same side. Any difference would be indicative of a leg length problem. 3 centimeters and above could well cause postural problems. The therapist will now check the patient's range of movement by taking them through active, passive and resisted movements. The active movements are assessed in standing and the passive and resisted movements are completed in lying. During active movements, the patient is standing close to the couch for stability. He is asked to flex each leg alternately at the hip. After turning, he is asked to extend each leg, making sure that the leg is kept as straight as possible. The movement is now taken into abduction again, keeping the toes pointing forward and having completed abduction, adduction is performed by crossing one leg over the other, again looking for any difference in measurement or pain and discomfort. The medial lateral rotation is performed with the patient sitting. The knees are close together, and by taking the feet apart, this will measure medial rotation on looking at the angle of the movement. And if he takes the knees apart and crosses one leg behind the other, that will indicate lateral rotation. Again, we are looking for angles to be similar. The patient is now put in the back-lying position for movements, starting with flexion of the hip, pushing right up and then flexing with the knee at the same time, and also checking out the hamstrings by going into full hip extension with the leg straight. The knee is held at 90 degrees and medial rotation is achieved. And then lateral rotation, looking for any pain and discomfort. In order to measure the abduction, one leg is stabilized and the sideways action stretches the adductors. This is repeated on the other side. By crossing one leg over the other and stabilizing the knee and pulling the leg across, then the abductors are put on stretch. Both sides are checked. The patient is then asked to turn over onto their front, and we are going to look at stretches for the front of the leg. so the hip flexors are put under stretch. Then moving to resistance, and by putting a hand onto the back of the thigh, we are resisting gluteus maximus. And if we then ask the patient to bring their heel towards their bottom, we are resisting the hamstrings. Turning onto the side allows us to give resistance to the hip abductors by putting a hand on whilst the patient pushes up. And by putting the hand underneath, supporting the knee, whilst holding the inside of the leg, the patient pulling in, the adductors can be resisted. The patient is then turned onto their back and the knee flexed. The resistance can be given to the hip flexors, primarily iliopsoas, and if we bring the leg down, putting the forearm under the bent knee and resisting extension, we are checking out rectus femoris. If we bring the leg straight and ask the patient to push down, we are checking the upper hamstrings. And if we hold the leg into a medial position and ask the patient to roll out, we are checking the lateral rotators. And if we ask the patient to roll in, we are checking the medial rotators. Palpation of the bony and soft tissue structures will show any areas of tenderness or pain in connection with the injured structures. With the patient lying on their back, we can palpate the anterior superior iliac spine, going down to the origin of rectus femoris, moving down the leg to the quadriceps and down as far as the knee. If we bring the leg slightly out, we can actually feel the inside structures, the adductors starting with pectineus, moving down to brevis, longus, magnus, and gracilis. From the outside, we can feel from the iliac crest, the greater trochanter moving down the gluteus medius and minimus muscles, the TFL and the iliotibial band. By moving the patient onto the side, we can feel from the iliac crest, moving down into the main muscle, the gluteus maximus, feeling around into the deeper piriformis, which is a deep lateral rotator, and then we can feel down into the origin of the hamstrings, the ischial tuberosity, feeling down the hamstrings themselves, biceps femoris, semitendinosus, and semimembranosus.